This conference will now be recorded.
So, hello everyone. We are just waiting for other members of the advisory group to join us. So please stay online. We are going to start in a few minutes.
Hi, Saki. How are you?
Hi. Hey, Fide, did you just send me a note asking me to make you presenter?
Wait, what? Can you repeat that again?
Did you just ask me to make you the presenter?
No? Do you want me to? I think I'm gonna be the one advancing the slides. Yeah.
Yeah, no, I thought, I see a note in the chat. Do you see the chat note? I wasn't sure if that was from you.
Oh, no, that was from Dr. Leon earlier.
Okay.
Yeah.
Should we wait for a few more minutes, Bob, or would you like to get started?
I think I'd get started, Jose.
Okay. So far, we have Alan, Jerome, and John on the line, but we can go, and Will. You know, we can go over if you want to, you know, and introduce ourselves and then talk to the advisory group.
Sure. I think somebody just joined.
That's MedCentro.
En MedCentro proveemos estilos de vida saludables. Somos una organización.
There we go. And then we have Cesar as well from Sanos in Puerto Rico, Bob.
Okay, great.
Hi, everyone. Cesar is here.
So glad you could join us. Jose, you want to kick it off?
Of course. Well, good afternoon, everyone, and good morning if you are on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. It's such a great pleasure to see some very familiar names on the list. So welcome. This is our first advisory group conference call for this program year that we started on July 1st of this year. We hope that everybody is doing well despite the COVID-19 pandemic and all the issues that we've been dealing with for the last few months. Thank you for all your work, for everything you're doing to offer care to all the low income and vulnerable and special populations that you serve. I have with me today the NCHPH, the National Center for Healthy Public Housing staff, and we would like to discuss with all of you a couple of issues that are current issues as well as some emerging issues and get some ideas as well. I will ask our team to introduce themselves. So Bob.
I am Bob Burns. I'm the director of the National Center for Public Housing, and it's great to see you all here. And we've got kind of an action-packed agenda. So once we get everybody's intros done, we'll try to keep it moving. Saki.
Hi, Saki Malik Cho. I'm the Director of Research Policy and Health Promotion here at NCHPH. Thanks so much for all of you to join and taking the time out of your day to be with us this morning.
And hi, my name is Frida Pineda, and I am the research assistant here in NCHPH.
Excellent. So we can go over and see who is on the line. So I see Alan Cintron.
Hi.
Alan.
Good to see you all.
Thank you, Alan. Hope everything's well.
I'm here with Carmen Portalatin, Francisco Vallanilla, and Lydia Figueroa.
Excellent.
Great
to hear from all of you guys.
Good to see you.
Cesar from Sanos.
Hi, everyone. I'm here to help with the team, and nice to see you all.
Excellent. Thank you, Cesar. And then we have Jerome. Jerome, can you please introduce yourself?
Hi, good afternoon. This is John from Primary Care Health Services. I'm the Associate Finance Director there.
Okay. Thank you, John.
Good.
And hi, Jerome Gloucester. I'm the CEO and Chief Medical Officer for Primary Care Health Services.
Excellent. Thank you so much for joining us.
Great. Thank you.
I see John, who already introduced himself. Who else do we have? We have Neil.
Oh, hi, everyone. Neil Kazuma. I'm with FQHC called Bay Area Community Health in serving Southern Alameda County and Santa Clara County.
Excellent.
Thank you so much for joining us. We have Sarah Lang.
Hi, I'm Sarah Lang. I'm CEO with Valley Healthcare in Columbus, Georgia.
Thank you so much for joining us. Veronica, very nice to see you on the list, at least virtually.
Hi, good morning, everyone. This is Veronica from TCA Health in Chicago, and I'm going to be joined by Samantha, our COO, shortly. So she's in another office. We're juggling. You know how it is. We go from one Zoom to another.
Mm-hmm.
Yes.
Glad you're with us,
everyone
Veronica.
is doing well.
Yep.
Thank you. And I see Wayne. Hello, Wayne.
Wayne, can you see us?
I think you're muted, Wayne.
I think you're muted, Wayne.
All right. So good to see you, Wayne. We hope that
I think I'm unmuted now.
there you are.
Oh, yeah. Well, Wayne Rowe, I'm President and CEO for Quality of Life Health Services, and glad to see all of you this morning, and looking forward to a very productive meeting.
Hope things are well in Gadsden.
You're going great.
And I see also Will. Hello, Will.
Will, I'm the Foundation Program Officer at Bay Area Community Health.
All right. And I'm not sure if I am missing someone here. If I am, can you please introduce yourself?
Johnny O'Brien, with Bay Area Community Health, Chief of Strategic Development. Glad to be here.
Okay.
Thank you so much for joining us. Next slide, Fide. Well, again, good afternoon or good morning, depending on where you are. Thank you so much for joining us today. We have an agenda that we would like to discuss with you. We would like to go over some of the current and emerging issues affecting public housing primary care grantees as well as public housing residents, and discuss with you some of the training and technical assistance needs that you may have. We also would like to talk a little bit about COVID-19. This is our current issue, and I know that everybody is doing a lot on COVID and helping your underserved population. So thank you again. Thank you so much for all your work and everything that you're doing. And then we would like to have a very quick conversation on a toolkit that we are developing. This is a toolkit that we developed probably a few years ago, and this is the moment to update the information, and we would like to get some information from you and some advice. So Bob, I will turn it over to you now, since we are going to start talking. But next slide, Fide.
Okay, well, I mean, there are a host of, major issues, that we want to get through today if we can, across the board, and get a little bit of feedback from you guys as to how those issues are impacting you. And I don't know if Jose, if you have anything to offer on some of the I guess the, best practices that we've bumped into during some of our training and technical assistance offerings over the last few months, or if you just want to get into feedback from the members.
Sure. Well, first of all, these are some of the current issue and emerging issues that we have discussed with some members, some health centers. Everything that is related to the pandemic response, the telehealth efforts and challenges, and everything that you're doing through telehealth and addressing not only management but prevention of some chronic medical conditions and other issues affecting your populations, as well as offering preventive services to all your patients. We have been discussing a couple of things with the health centers regarding health literacy, computer literacy, health numeracy, and everything that is that is affecting all your patients. Then everything that is related to population health. This is another important topic that HRSA is paying attention to, as well as other federal organizations. CDC and HHS in general are very focused on population health. So this, and I am quite sure that you, when you have your quality assurance meetings, or you address the population health and everything that is affecting your population, the population in your community. Another issue that is very, very important to discuss, especially because there was some information from HHS regarding cybersecurity, and how hackers are trying to get information, private information from health organizations, and not only hospitals, but health centers, and including organizations like the National Center for Healthy Public Housing. So I am quite sure that you've been working on cybersecurity as well. And then the last two issues that we've been discussing and are very important for HRSA are the patient experience, which is another issue that is even in the HRSA strategic plan, and the effective payment model that everybody is working on. So these are the kind of issues that we know, based on what we have heard from the health centers, that are affecting public housing, primary care grantees, and health centers in general. So we're talking about all health centers. So I'm not sure if there is anything else that you have seen, you would like to add to this list. Probably we are need to start working on our training and technical assistant work plan by the first week of January, based on HRSA's requirements. And we are planning to address some, if not all of these issues, depending on the response that we get from all of you today. So I'm not sure, and I'm going to stop for a moment and ask if there is anything else that you have seen and you would like to discuss, or you would like to get some training, not only for those participating on the call, but for your staff.
While people are thinking, we're talking about the work plan for next year, for the work plan starting July 1st of 2021. So Alan or Wayne, any thoughts on any major issues that you think we really need to make sure we include in our training for the next program year?
Well, I think you've covered most of the issues there. Perhaps I could add anything right now.
Okay.
Sarah.
I'd like to bring something on board. Despite all the pandemic, COVID-19 pandemic has implied, and in our case, we come way back from our Hurricane Maria and then the earthquakes. We have many lessons learned throughout all this period, and it seems like Hurricane Maria kind of prepared us in Puerto Rico to take at least a little bit better care of the pandemic. However, each of these three events are completely different from each other. However, I bring this because you just mentioned the chronic conditions, and as a result of the Hurricane Maria, we built the chronic conditions clinic specialized for Southern Puerto Rico. Now, when we have the earthquakes and now the pandemic, we have that in place. So the point I would like to bring is that if we can also focus on those very good lessons that we have learned, how we have coped with them, and how can we use them for the future of our health centers. In our case, that we specifically work with the public housings, where we're working our way around in order to access the public housings in the mobile units. Logistics have changed. We have had to kind of step back a little bit, but actually we're already going in again with all the security measures. So I guess the point I'd like to focus in is that there are many opportunities ahead of us, and many lessons learned that we can work together, for a better future. Specifically, the pandemic led us to construct and build a telemedicine and a call center, which was not in our plans. We had a call center, and when the pandemic came, we turned it into a telemedicine mode, and now we are going all the way with telemedicine, and so much funding was available for telemedicine that kind of paved the way for us to now go into telemedicine. However, that said, in the case of telemedicine, I know that's one of your point of telehealth, if you want to call it. That said, the beginning, we switched. We were able to continue providing services, and 90% of our services were provided through telehealth. Today, it's around 60% telehealth, 40% physical exams We call it face-to-face encounters with physicians. So how is it going to end? Well, the story ain't finished yet, but we believe it's going to be anything near the 50-50%. So what the pandemic has done for us is that the telehealth was already there, and it kind of shortened the time for making telehealth, a way of providing healthcare and access to more people. For instance, you have a patient who comes to have a physical exam by his physician, that is a face-to-face encounter, or laboratories are ordered. So the next visit not necessarily has to be another physical exam, and the physician can have a phone call or a virtual face-to-face encounter with the patient. So that brings a new access point, for our patients. So there are many lessons learned. That's a key point.
Thank you so much for sharing that information. That is great information, and we are planning to use, your lessons learned and any best practice that you have in place. This is something that all health centers are always interested in. And in addition to all the general information and overview that we can provide on a particular topic, they always are very, very happy to hear from other health centers about any best practice or anything that you have in place that can either duplicate or somehow modify. Now, in regards to the pandemic, and thank you again, for that information. If I understand this correctly, we are talking about training on not only on emergency management, I guess, because the pandemic has been like a trigger, to improve our emergency management or emergency preparedness response. But I am also hearing from you some issues regarding workforce, if I'm not mistaken. Am I correct?
But
Jose, is that question to Alan?
Yeah, that's a question for Alan.
Okay. I didn't hear you completely. Can you bring it
Sure.
back? Bring your question.
Thank you, Alan. In addition to the response, and emergency management, probably more training on emergency management. And as you mentioned, the pandemic is just one of many emergency issues that we can face next year. Puerto Rico is located, in an area where you have hurricanes, basically the entire season, and you are always, on the path of any of these hurricanes. And then you also mentioned the earthquakes, and you mentioned the COVID-19 response. But the question is, in addition to emergency preparedness training, I believe that I heard you saying some training on workforce.
Yes, there is a very important training that I have not kind of observed that is being formalized, and is emotional preparedness. Actually, I think that is one of the key components of whatever other things you might be able to do. If your team is not emotionally sound or focused or sane, if may I say, then you're not going to be able to cope with the other problems. So I think emotional preparedness of the first responder, which is in our case all of us, it's a very important phase. And I have not quite seen that. We kind of focus on other things, but not in preparing our people emotionally. And you have to be strong. We compare this as sometimes as a state of war. What are you going to do if your colleague is weak? and you got to take care of patients, then you're going to be weak as well. How do you cope with that? How do you prepare your management? How you prepare the people for maintenance? How you prepare your drivers, your nurses, everybody to be ready and be aware and be knowledgeable that we all are first responders. I mean, we can't stay at home. We are the ones who have to be upfront, and you have to be emotionally prepared for that, because otherwise everybody will stay at home after the hurricane or after the earthquakes or during the pandemic, and you have to work with that.
Yep. Thank you, Alan. Thank you so much. We're going to definitely address those issues that you mentioned, and we're going to reach out to you, to see whether we can work together and offer some best practices for the other health centers while we prepare our training for the next program year.
Jose, one more thing I'd like to bring, another very important point. Health centers, there is, and this is at the government level, always hospitals are seen as the first responders, when in fact it is the health centers, us, who are the first responders. We are the contention wall that prevents loads of sick people falling into the hospital, which should take care of emergencies or acute care or whatsoever. But every promotion or every announcements I see always focus on hospitals, and they bypass the importance of the health centers in the communities. For instance, in Puerto Rico, you have, I think it's around 60 hospitals, from very small to larger ones. But you have 100, I think it's 110 sites, health center sites, spread all over the island in the communities. And we can take care of vaccination tests much better than hospitals can. But that is not the case. Every time the government comes out, it's out there in the hospitals. This is nothing against hospitals. This is pure logistics. And I think government has to start seeing health centers as first responders, as the contention walls that prevents tons of people from getting sick or not getting the service. In going back to Hurricane Maria, the deaths because of the hurricane, because of traumatic deaths during Hurricane Maria were, I think, 4 or 5, no more than that. However, deaths accounted for because of chronic conditions not taken care of or whatsoever were near 3,000. If those people would have to be taken care of, probably would have been much less. But the hospitals could not take care of that. Emergency rooms are not designed for that. So I think we have to continue make our policymakers focusing the importance of healthcare centers spread throughout the whole nation.
Yeah. Thank you so much, Alan. Again, I mean, those are great issues. And I'm not sure if Sarah Lang would like to. I believe that you wanted to chime in on the conversation, Sarah. I'm not sure.
I think Alan echoed. I mean, he was saying exactly what I was going to respond to as far as preparedness. But I was also going to talk about and this is probably part of the pandemic response that we're seeing here in Columbus, and having Fort Benning Army base so close in one of the hot spots and remains so. The partnerships developed within the community and the response that we're having to forge together, and that's probably part of that emotional and emergency preparedness, that they must recognize not only those very large institutions such as hospitals, but they're also having to, we have to include those organizations such as the Department of Defense and the community health center community with any response, whether it's the pandemic or moving forward into, as everyone is saying, a new normal. We've got to respond collectively and holistically in our response and our plans. One of the big issues too I wanted to talk about was the response. Immunizations. I have never seen people that are running away from immunizations. It's a big campaign that we're trying to put together to say, you've got to have this flu vaccine. Let us prepare for the vaccines in response to COVID. And I'm sure you've heard the ideas and miscommunication about the vaccines, and I'm not going to get it because it was already developed and they're just going to experiment on me and I'm not going to have it.
Yes,
so,
correct.
with all of this, there has to be that mass communication from those of us on the front lines and in community health centers as well. So echoing many of the things that Alan said.
Thank you, Sarah. And, and this is a very good opportunity because one of the topics that we are planning to discuss with you is some efforts that we've been involved with HUD and HRSA in regards to influenza vaccination and how to prepare, for the probably the next phase, which is going to be to vaccinate patients against COVID and all the miscommunication that you are mentioning. So next slide, Fide. Bob, I will turn it.
Just run through this quick.
Good, just because I believe that you would like to talk about the HRSA strategic plan and what you're doing with an NRC.
Yeah, I mean, one of the things that we've been working with as a National Training and Technical Assistance partner is the National Resource Center, which offers healthcenterinfo.org. And it basically consists of all the other training and technical assistance partners, Healthcare for the Homeless, Migrant Clinicians Network, Capital Link, there are 21 of us. And what we're trying to do is to try to offer training and technical assistance that supports HRSA's strategic goals, which apply to all of us and health centers in particular. Improving access, fostering a healthcare workforce, health equity through enhanced population health, and optimizing operations and program management support. Next slide. Okay, and so on the left are basically the goals, and they're basically the HRSA goals, except that on goal 4, the NTAPs, the National Training and Technical Assistance Partners, us, want to strengthen our operations and program management. But we have 3 main objectives to support the overall goals. One is to increase awareness and utilization of our training and technical assistance through partnered branding, marketing, and outreach. Things like the healthcenterinfo.org. Collaborations on various trainings to make sure that we're offering just-in-time training and not overwhelming folks with competing trainings, but rather they're complementary trainings. 2, to develop and provide high-quality, harmonized training and technical assistance services and resources that help build health center capacity across the BIPIC 7 domains of health center excellence. And the word harmonized, is a word that we struggled with in developing it, because not only are we hopefully singing off the same sheet of music, but we realize that when you're doing any good multi-part harmony, there are certain parts where certain singers are singing and other singers are not singing, and then there are parts where everybody's singing together, and we're trying to achieve that. And then last, to support and demonstrate accountability. So we're trying to measure our worth and show that we're actually providing valuable services to health centers out there. And that's why our evaluations, which, after every training and technical assistance activity, somebody asks you to fill out an evaluation, and that's why it's so important. But next slide. But right now, as part of that effort, we're going through this exercise. We're trying to have more of a connection with HRSA as a group. In fact, we have a meeting with HRSA next week. And I guess one thing that we wanted to ask you guys is, what do you need the Bureau of Primary Healthcare to know? What do you need Jim McCrae to know, or Sue Manier to know, that we can pass along? What do health centers need from the Bureau? And overall, how can we help you, get that information or get that message to them or get you the training you need? But if there were a couple of things that you wanted to say to Jim McCrae, and company, tomorrow or today, what might they be, on any of the subjects that we're talking about, whether it, and Jose, before we set up the slide, Jose said, I'm going to preface this by saying anything you need from the Bureau except for more money, because I know everybody wants more money, but in addition to more money, or what might you want to use that money for? What are some of the things that you need and you want them to hear? Or what are some of the challenges you're facing? Any of that good stuff. Wayne, how about a quality of life? What right now is kind of, I guess.
Hi, Bob. Monica, I'm sitting here with my COO, Samantha, when you just mentioned,
Okay.
I have my mask on. Can you hear me well?
Yep.
Yeah. So when you mention that money, no, we're drowning in money. At least folks in Chicago. Yes.
Wow.
Because
Okay.
we had a lot of money all at once, and we have to figure out how to use it. What we want is less restrictions. If you're gonna give us the money, don't chum up all of that stuff and say you have to use it for this. Because if they didn't give us the money, a lot of health centers would have been out of business, but they weren't the only ones giving us the money. Everybody else was giving us money. Foundations, everyone giving us money for the exact same thing.
Yeah.
So we're saying ease up on the restriction, because I know they're looking for accountability, and but it's like, man, you're helping us because we need help. You want to keep us in business, but then you put these restrictions at the dollars. It's like all the same amount, all this money for the same thing. We're running out of ways in which we could use the money.
Can you give an example of some of the restrictions?
Give me an example, Samantha.
Or even just one.
Okay. Allocation to COVID testing, COVID response, and then being very specific about how it could be extended on direct services. Relief fund, PPP covers salaries and maybe a little bit of mortgage and utilities, but it's not really. I think our foundation has been helpful by saying.
Hey, Veronica, we're losing about 2/3 of what you're saying.
Okay. Okay.
Our foundations have been very clear in saying you can use the funding for any general operating expenses.
Okay.
Whereas HRSA had very specific grants, whether it was HD was supposed to be for one thing, HE was supposed to be for COVID testing and expansion. Could use it on, medical provider retention. So they were very prescriptive about how to utilize the funds, rather than saying, what do you need it for? Yeah, the exclusions, use it for anything other than lobbying, so that it can truly be general operating funding, and people can use it to fill the gaps rather than trying to make it fit what they thought it should be. And again, that funding was issued in April and May, and the pandemic has changed the need so much since then. You know,
Yep.
we thought that something was going to last for 3 or 4 months. And
Mhm.
now it's a complete, 8, 9 months later, we haven't really revised what that funding should have covered.
Right, right. No, that's a great point. And I think part of the issue, at least for them, is that some of it has to do with the legislation itself. But at the same time, they can work with legislators, to try to address those issues up front, because especially some of these spending issues around COVID related testing, because we had an issue around flu vaccination where people wanted to use some of the ECT funds for the cost of having to buy doses of flu vaccine, and they weren't able to do it because that was really limited to funds being used for testing purposes only. So yeah, I know just what you're talking about. And the foundations.
Well, I think another area, and I was asked earlier, has to do with technical support on how to deal with some of the issues that Sarah mentioned earlier about the community education. And we certainly could use some of that, trying to figure out how to do better outreach in this day and time, with the COVID there. So we could use that kind of support, expertise from the Bureau.
That's excellent. Thank you, Wayne, and thank you, Veronica. And I see.
Jose, excuse me.
Sure, go ahead.
Alan, excuse Alan, he had to step out a minute. And he told me to ask, where does HRSA stand with the quality compliances for 2020 and for 2021? That he would like to take to them and ask.
Okay, all right.
Very good.
That's a great question. Thank you.
Excellent. Yep. That's very helpful. And one thing, Wayne, and you were referring back to Sarah, and Sarah was talking about the need for kind of a coordinated approach to some of these issues, and I'm sure, and certainly the pandemic and flu is an example of that. And I'm just wondering if any of you guys have had an experience where you saw that kind of cross-sector community coordination, that everybody kind of dreams about. And is there anything that would help you achieve that, I guess, or have you got any examples where you've seen it work that way?
I don't have any examples, but we have experienced issues in terms of we ourselves set up community projects for vaccine, flu vaccines, and carried our teams out to certain locations and communities and had very little response from the communities, although we did a lot of advertising.
Yeah.
Prior to that.
Wayne, did you coordinate with the housing agency at all?
Yes, we did. Yes, we did.
Was that successful or?
No, it was not.
Yeah,
I think so. We just need some help in that regard.
Yeah.
Okay. Because I know HUD is willing to kind of support that kind of effort. So anyway, but we can talk about that. Jose, go ahead.
Bob, there is a comment in the chat from Johnny. It seems that he would like to discuss with HRSA as well the provider relief fund. I'm not sure if Johnny would like to provide more information on that.
Hi, thanks. No, I was just adding that there. I think to the first comment that was made, I believe from Virginia in regards to the funding and the restrictions and so forth. And so I put that would probably be an example of what she mentioned in terms of the restrictions that that's placed upon us. I think that I believe we're in the phase 3 of the provider fund distribution, and there are certain restrictions there that have set for health centers. And so I just put that there in the comment.
Okay. That's excellent feedback and an excellent example. Thank you, Johnny.
Yep. And I don't know if that's connected to some of the notice here, because I mean, vaccine can get fee reimbursed by patients' public or private insurance company, or uninsured patients by the Health Resources Administration's Provider Relief Fund. So I think it's something worth talking to HRSA about. So I'm glad you brought it up. And it's funny because I got a notice on it, because we're on this or associated with this healthcare resilience working group, which was working on this flu lead program. I got a note from one of the fellows there today asking about the very same issue. So I think it's definitely something we'll go back to them on. Yep. Thanks an awful lot for that.
This is Zara from La
Hey, Zara.
Maestra. How are you? Hi, I'm sorry. I apologize for jumping on late, and I
Well, we're
hope that
glad
my
you did.
input here. Thank you. I hope my input isn't something that somebody else has already said. But you know, we would like to ask HRSA two important questions. One is, what is their stance going to be continuing forward on telephonic visits? Because we know that CMS's definition of telehealth does not include telephonic. It includes, you know, face-to-face.
Yep.
And so obviously after the emergency, you know, status is done with COVID, if that ever happens, you know, I really like to see, you know, I guess more assurance that telephonic visits are going to be, you know, accepted,
Reimbursed.
you know, maybe not for every service area, but certainly behavioral health and mental health and other kinds of visits. Then the other question that you put out there about integrated kind of services for patients out there involving other sectors, I'd say that, yeah, you know, case management, when we refer patients not only within our circle of care, but through our partners in our network for social determinant services like housing and legal assistance and food scarcity, we have to keep track of all of those referrals. Did they make it there? We capture that data. I mean, that is something that HRSA does want to encourage. You know, everybody's been talking about social determinants. I know we've spoken about it how many times, and the coordination of it. But like, you know, we see some small programs coming out from the health plans, like the Health Homes Project, you know, which is connected to the, you know, the whole person care. But that's just for a small subsector of our population that we work with. What about everybody else that's getting, you know, thrown out of their homes, or they're homeless? They have, you know, multiple complexities of health issues and adverse social determinants. So, you know, like, when are we going to start seeing some reimbursement for these social services?
Okay.
Thank you, Zara. That's very
great question.
Yep. Thank you. Let's move on, Bob.
Yeah, we're tight on time. Sure.
Yeah.
Go ahead. Okay.
Another issue that we would like to briefly discuss with you guys. By HRSA's requirements, we have to conduct training either, and this is live training, either hosting learning collaboratives or webinars, or either regional or national conferences. And we have a couple of issues regarding participation. You know, we would like to know, I mean, we have a list of all of you, you know, and all the information that is provided by HRSA on how to contact the CEOs, the COOs, the CMOs. But sometimes the training is for those of staff members, you know, we don't have access to, like outreach workers or any of the enabling services people. So the question is is there any way that we can communicate with them, or is the best way is to send the information to all of you guys and you can forward it to your staff?
I think that's better, Jose. This is Zara, because then I know who on the staff is appropriate and has time to, you know, and is appointed to this area to deal with.
Yeah.
Excellent. Thank you, Zara. And then in regards to topics, as Bob mentioned, the 21 national training and technical assistance partners working on a needs assessment. We are planning to cover different issues, and I believe that we have already discussed some of the priorities that you have. So we are going to make sure that some of the information that we just got from all of you, is communicated to the group on the needs assessment for this program here. Next slide. All right, Bob, all yours.
Okay, I'm going to talk fairly quickly about, we're going to get back to COVID-19, but obviously COVID-19 has brought to the forefront the importance of immunizations across the board. And one of the things that people are fearful of is the twindemic of COVID, plus flu, and so thus the flu lead program, which I'm going to get into in just a second. So let's switch slides. Go ahead. Okay, so flu lead was designed to increase flu vaccine coverage during 2020 to 2021. It's kind of been just a pilot program. Right now, we've got 15 sites that are following it, but the goal was to increase vaccinations, enhance health and resiliency of residents of HUD-assisted communities, and really importantly, to foster partnerships between HUD-assisted communities and HRSA-funded health centers across the board. And one thing that is really great that has happened over the last couple of years is that HUD is a very staunch supporter of health care for residents. Now, it's kind of just trickling down, I think, to the public housing agencies, but at headquarters, they've been really behind it. And in fact, next slide, as far as this flu lead effort, they have really been, of all the agencies involved, and BIPIC's been involved, and CMS has been involved, and the Agency for Healthcare Research and Quality has been involved, and the Office of Minority Health's been involved. But it's the fact that HUD has really bought into and been a leader of this effort that has made, and I think hopefully will continue to make the difference, because the folks who have been taking the lead are not political appointees, rather they're career folks who will be around after the transition. So we're really hopeful about that. But right now, 15 pilot sites, they were matched together, health centers, public housing agencies, using Envision Center locations and Jobs Plus locations in those sites. But there have been a lot of challenges. The first, of course, being that this is a brand new program. People are just not aware of it. And the timing of the program was not great, because the flu lead was developed after health centers had already put in their requirements for flu vaccine for the year, which really caused a problem down the road. Because unfortunately, due to COVID, there's been a great interest across the country in getting flu vaccine. And so as a result, when a lot of the folks who expressed interest in flu lead went back to their state immunization program managers, they were basically told that they could not get the doses they were looking for. We had a health center in Texas, in Fort Worth. They've got 14,500 patients, and their state immunization program was able to give them 650 doses of flu vaccine. So they had to go out and because they were committed to this, to find their own sources and find other funding. The next issue was reimbursement. So how were they going to be reimbursed if they had to buy vaccine, if they didn't have funds to do that? And how are they going to deal with the mechanics of people lining up to get flu shots who might not be health center patients or might not have an insurance that has a relationship with a health center? And so what one, I thought, creative solution was, they actually took some of the funding they were able to find, and they actually gave, in partnership with the public housing agency, they gave those residents a voucher that they could bring to the vaccination or to the immunization clinic and simply give it to them without any other, kind of reimbursement or funding or insurance or whatever, just to simplify the process. Of course, they also use it as an opportunity for non-patients to try to, encourage them to become patients of the health center. But the course of this program has been a little bit rough because, again, it started late. There was not really a lot of funding behind it. There was not a lot of resources behind it, even though everybody agreed it was a good idea at all levels. The 15 pilot sites are going to progress, and hopefully this will work. But really, at this point, we want to build for next year. And one of the biggest things we can do is to get the word about the program out and to make sure that people are getting requirements in for public housing residents, patients or not, in advance, so they have plenty of vaccine available. Because honestly, at least for the 15 sites, that seemed to be the biggest single issue, which seems kind of crazy, but it was the case. But it's also hopeful. And now, and more importantly, this is kind of an opportunity for housing agencies and HUD and HHS to work together on vaccinations. And of course now, and the entire flu lead was a function of what's called the Healthcare Resilience Working Group, which involved a whole bunch of federal agencies, HHS, CDC, and HUD, and Department of Labor, and a whole bunch of others. But the real reason it was created was to focus on COVID, and it focused on flu lead just as an ancillary activity to support, COVID fighting activities. And so now, hopefully, we can take lessons learned from that and move on and use some of these relationships and some of the lessons learned to be of some help in the distribution and immunization for COVID-19 as the vaccine becomes available for the next 1 to 4 months. Next slide. And these are just some stats. I mean, obviously you all have a lot of experience vaccinating patients, across the board. And we want to take advantage of some of that experience and hopefully use some of the experience and lessons learned, of the past, 50 years of community health centers to use to, first take care of, I guess, the urgent need, which is flu and more importantly, COVID-19. And then also to make sure all those other immunizations that have slid over the past few months, childhood immunizations and so on, occur. Next slide. And then I'm going to let Saki just kind of go through a little bit of some information on some testing capacity and some other information about public housing primary care centers and COVID-19. Saki?
Hi, Bob and Jose. I just want to check in with you about the use of our time. We are at the hour, and I have about a dozen slides to get through. So how would you like for me to proceed, Jose and Bob? Would you,
let's ask the advisory group whether they have some time. Otherwise, I mean, we want to be very respectful of your time. Can we have like 10 more minutes of your time, guys? Okay.
Okay.
Let's do it.
Okay, go ahead, Saki.
Okay, great. Thank you so much. And I can move through these fairly quickly. I just wanted to show you some of the data and information that HRSA has been collecting from all health centers since the beginning of this pandemic. This is the weekly survey that HRSA asks health centers to fill out about COVID-related metrics. And I have extracted the data for public housing primary care. So this is the information from PHPC health centers. So this first slide shows just some basic information on the number of health centers that have COVID-19 testing capacity. And you can see that was a big challenge and issue during the beginning of the pandemic, and in the early months, it was quite low, around 85%, but this last week, you can see that 100% of health centers have the ability to test for COVID. So it's been a huge increase. Next slide, please, Fide. And this is shows the number of patients that have been tested for COVID. And you can see that the number of tests has increased based on availability of the test to health centers. So you can see lower numbers in the beginning and then shooting higher recently as the need for additional COVID tests increases because of the season, the winter season. Next slide, please. And these are the number of positive COVID-19 patients seen at PHPCs from April to November. And you can see that this reflects national statistics as well, with spikes in the early stages of the pandemic, as well as the summer months, and starting to increase again as the winter month. Yes, go ahead, Alan. Alan, did you have a question? No. Okay, sorry. Next slide, please. And then we also wanted to show you the percent of patients that are racial or ethnic minorities that are testing positive for COVID. This is something that we highlighted in an earlier conversation that we had with you in the beginning, when we were all kind of shocked to see that the rates were around 80 to 85% of the patients were racial or ethnic minorities. Now we know and nationally that this is a challenge across the country for racial and ethnic minority populations, and it's kind of stabilized around 70–75% within the last month. But for all of the reasons that we know that affect our patients, the SDOH issues and challenges, and all of the other chronic health conditions, this is consistent with all of the other challenges that racial and ethnic minority patients face. Next slide, please. So this is a slide showing the weekly visits compared to pre-COVID times. And this is just to reflect a little bit on what Alan and Sarah were saying about, and Veronica, everyone pretty much saying about their use of or need for telemedicine and telehealth visits, because their weekly visits have declined so much compared to last year. In the beginning of the pandemic, you can see around 50 to 60% of weekly visits compared to the previous year. And a lot of that has to do with the newness of the pandemic, stay-at-home orders, trying to triage your patients to see only chronically ill patients or high needs versus well visits. And you can see as health centers have started to address all of the needs and challenges of creating a space that can adapt to COVID-19 and COVID-19 patients, that the number of weekly visits has increased. It's still a little bit lower than last year, but definitely better, around 80% in this last week. Next slide, please. And then this shows the percent of health center visits that are conducted virtually. So in the beginning, you can see high rates, 60 to 70% of the visits were done. And this is virtually, so it could be telephone, it could be video calls, online. And then it started to stabilize around 35% within the last couple of months. And just a quick note, last year, according to 2018 UDS data, only 44% of PHPCs were saying they were using telehealth services. In the beginning of the pandemic, HRSA surveyed everyone, and it was 94%. So there's been a huge shift as everyone has tried to grapple with all of the needs for delivering services to patients during the pandemic. And as everyone has suggested, that'll probably continue on. And so addressing all of the challenges that health centers face, not only with training providers on using telemedicine, engaging patients electronically, as well as having the infrastructure needed to provide telehealth services and the reimbursement challenges going forward. Next slide, please. I'd also like to talk about how the pandemic has affected health center workforce. So this shows the percent of staff that are unable to work due to site service closures, exposure to COVID, family obligations, lack of services. And you can see that health centers were really affected largely in the beginning of the pandemic, and now it's stabilized around 5%. But this is an aggregate of all PHPC data, and there are many health centers in hotspots across the country that have 15 to 20% of their staff unable to work because of all of the challenges, a lot of it having to do with PPE supply as well. Next slide, please. And the number of staff with positive COVID-19 has also fluctuated and is starting to increase during this current wave of COVID-19. Next slide, please. And this slide shows the number of sites that have been temporarily closed due to COVID. Next slide, please. Okay, now we're at our toolkit, Jose, and I just want to check in again with you guys about the time. It's almost 10 after the hour. And this is a longer discussion. Bob, what would you like to do?
Again, if people can hang in for 5 to 10 minutes, let's do it. If they can't, understand. But Wayne, I don't know how you look, or Alan, or Veronica, or Will, or Sarah.
I can hang in.
This is Veronica and Samantha. We're good.
Okay. I just wanted to check in and make sure everybody we understand how busy you all are.
The centro's
Okay.
good.
This is Zara, and I'll be happy to hang in. Thank you. This is great information. And Saki, could you please email me this presentation that you're doing here?
Yeah,
Thank you so
sure.
much.
And yeah, no problem. And just to let you know that all of this COVID data that I've presented to you is available on our website. It's I create an infographic every time we get new HRSA data. So every Friday I analyze it, and it's on our website by the next Monday or Tuesday. And we're hoping to develop a dashboard of all of this data so that you can look at it on our website, and hopefully that will be created by the end of next week. So just to shift focus here, as Bob and Jose mentioned, we have a toolkit that we developed about 10 years ago that we are trying to refresh. And now is a good time to kind of take stock on what was included in the toolkit, and have an opportunity to shift the focus if we need to. But we want to get your feedback on some major items, including making sure that we're developing this toolkit that would be useful to all PHPCs, both those that have had well-established partnerships, as well as those that are new to developing partnerships and need some assistance in building collaboration and improving engagement of public housing residents, as Wayne mentioned. Like I said, because we are refreshing the document, we can modify, expand the scope if we need to, include items that weren't addressed in the original, and as well as making sure that the document is in a format that is relevant for you all. So, a hard copy publication, is that the best, or is it more modules online, or how can we organize this information in a way that will make it useful? And then, asking you if you would be able to provide some review on a final draft when it becomes available. So just a question, is anyone on the call familiar with the original toolkit, or were any of you involved in the development of the original toolkit?
Yeah, this is Zara Marcellian. I believe we were with Jose.
Okay, great. So I think our first question is, should we include public housing in the name of the toolkit? So the original toolkit was called Partnering with Public Housing Authorities to Increase Resident Participation Certainly, we as an organization provide TTA to PHPCs and also health centers that are located and are immediately accessible to public housing. But we wanted to make note and realize that the public housing landscape is shifting. There's been a decline in public housing units and residents in public housing and more towards vouchers. So the question is, should we kind of broaden the name and the direction of the toolkit by using all HUD-assisted programs? Should we keep it even broader by just focusing on community collaborations in general, so that it could be not just housing authorities and housing agencies, but all of the other organizations and community collaborations that could help address public housing? So I'm going to pause there and ask you all your thoughts on that.
This is Zara. I think that's a great idea. Here in San Diego, nobody really understands what public housing is because we haven't had any new structures for how long, but it's all voucher subsidized housing in low-income communities, and that's kind of the way it is. So I believe to attract more people, I would keep it broader. That would be my vote for the name.
Great, thank you, Zara.
Okay, next slide, please. Okay, so here's the current organization. I know this is small, but here's the current organization of the toolkit. It has 3 modules. The first is a background on public housing residents and HUD and some demographic information, information on how housing impacts health and SDOH, how that's important for public housing, some of the health concerns affecting public housing residents, background on HUD programs. The second module talks more about collaborations, why it's important, how to engage the community, how to communicate with the housing authority, data collection and data sharing, barriers to collaboration, and then establishing formal agreements. And then the final module is on examples of community collaborations and promising practices. So for the first module, the question is, should we broaden the scope to include other HUD programs more broadly? So I'm going to pause. I think I heard from Zara that yes, we should probably increase it to other programs, but I just want to get a sense from everybody else. Is there some consensus with that?
Agreed. Must be broader.
Excellent.
Okay, great. And then for the second module, I want to ask you, are there any components of collaboration that should be addressed that you don't see on this list? And I should say that data collection and sharing was not in the original draft. We added that bullet based on a conversation we had with another organization that had done some focus groups on partnerships, and that issue was raised. So I want to pause here, take a look at this list, and let us know if there is another component to developing a partnership that you think that we should highlight in this toolkit. Okay, so it sounds like you guys are thinking about it. If anything comes to you, we can definitely add in. And then the next question is for module 3. Oh, Katie, can you go ahead and click a couple times? Yeah. Okay. The next question for module 3 is, should we include partnerships that are beyond collaborations with housing authorities? For example, there are Envision Center collaborations. There are collaborations with other local departments of health, faith-based organizations, schools, law enforcement. There's so many different types of collaborations. Should we broaden the scope of what we include? I'm going to pause and ask you for your thoughts.
I'd say yeah.
Saki, go ahead. I'm sorry. I also say yes, absolutely. Well-being is not just a trip to the doctor or the housing. It's, lots of other you know, the environmental contextual based issues that affect people, and you do need that partnership.
That's right.
That's a good point. Thank you. Thank you, sir.
Okay, so now that we're broadening the scope, we're taking a document that was maybe, I don't know, 15 pages, and we're going to increase it quite substantially with all of these examples and broadening it. So how can we organize this information in a way that will be useful for all of you? I mean, and doesn't just sit on the shelf. And so I'm going to ask you if you have any thoughts about the format of the document, and also if you've seen it or used a toolkit previously that you found that was really easy to navigate, and what did you like about it, so that we can, you know, make sure that we incorporate those ideas into this one. I don't have a problem with writing a long report. We can do that if that makes sense for you. But you know, I want to make sure that it's useful for all of you.
Saki,
Okay,
I'll just
Oh,
go ahead.
this is Samantha. I think it's important that it's visually appealing and that it's kept in simple language with examples. I think that's what sets a toolkit apart,
Yes.
is that it's very specific, but at the same time easy to read, so that whether residents want to engage with it or professional staff want to engage with it, it lays out a clear visual roadmap of what steps could be taken.
The other question, Saki, I believe, is whether they prefer a hard copy or if an online copy is the best option. You know, if you go to different agencies, ARC or the Minority Health and all those organizations, they provide online toolkits, you know, and the question is, in order to read it, would you prefer to have a hard copy or online copy, or both?
I'm old. I prefer a hard copy.
Okay. Thank you, Wayne.
You know, one other thing that we had talked about as an option is, like, you know, having sections of it which are kind of fixed, at least for a while, and then having a section that's best practices, where we can, you know, go ahead and as we identify new best practices, keep adding and deleting as we find new and better best practices, so folks can go ahead and see those, even though maybe the basic protocol or operation may not change, you know, change periodically, but not as frequently. So I don't know if people have a thought on that. And the other part of it is, and Saki, you've got it in your questions, or I think you mentioned it before, you know, we've had toolkits before, and we find that we get a lot of use of toolkits, particularly from new entities, new grantees and that kind of stuff. But then, you know, folks who've been at it a while, like you guys, you know, might not look at it. And we didn't know if we should create kind of a tiered toolkit, you know, where we have sections that are kind of, you know, geared for, you know, the newbie versus, like, you know, the advanced experience, you know, PHPC Health Center, for example, you know, kind of set it up that way. And I guess, what are some of the things that the more experienced health centers, you know, would be interested in from a toolkit?
Actually, I used toolkits that were for beginning a program, and I prefer to go back and refresh and look at it refresh all over again. To then think of new ideas. It's not so much that I need to include that in a whole new program or a whole new module.
Is that Sarah?
Yes, it is.
Sarah, we're losing you just a little bit of what you're saying. So, are you saying that you're interested in an additional module geared to your needs, or you're interested in kind of new information as it becomes available?
Only as it becomes available, not in really trying to put it into the toolkit. I like going back to the original toolkit and refreshing.
So thank you, Sarah. This is Zara now. I'd like to say that, we're always training emerging leaders from our organization. And so, this toolkit and the information there is always going to be necessary as we are mentoring and training up, the future leaders of our organization. So that's number one. Number two, there's always concepts there that help apply when you're developing new programs or new collaborations, maybe with a different sector that you haven't, previously built partnerships with. I think that's all very important. So yeah, I don't think it's just for new people or new grantees, I should say.
Okay.
Thank you.
Okay, great. Saki, do you think you have enough?
Yes, thank you so much for all of your feedback and for staying this extra amount of time to provide that. Thank you. I appreciate it.
Well, Jose, you want to bring us home?
Sure. Well, thank you so much for the feedback that we received. It's always such a great pleasure to see you all. Thank you, Alan, for the information on emergency preparedness and all the good stuff that you're doing, in Puerto Rico. And Wayne, it's always such a great pleasure to see you and get all that information, Zara and Sarah. And everybody else, who've been on this call. One more time, we would like to thank you all for all your efforts and everything that you are doing for your patients. We know that it's been a very hectic year, a totally different year, and we hope that we are going to get over soon. So stay tuned. I mean, we would like to discuss with you probably in the future about the COVID-19 vaccine distribution and all other topics. But in the meantime, I believe that we have received the information that we need, and at the same time, we have touched base with all of you and getting all this information. So again, thank you so much, and please do not hesitate to contact us at any time if you have any other questions or comments or whatever you need from the National Center for Healthy Public Housing.
Thanks, everybody. Really appreciate it.
Thank
Take
you.
care now.
Everyone.
Thank you.
Bye.
Okay,
Bye.
be well. Bye-bye.
Bye.
Bye.